degree thoracic, 66-degree lumbar curve. Is it a double major curve or C, also major curve? Make lumbar. You do bends, curvature, because lumbar is major classification. 42-degree curve. Look at translation of the on the sacrovertebral line. Like, so is this a speculum? Sorry, I have put a 3C there. Whether it's a major curve. Look at the lumbar curve. It bends. So that's the of very flexible what it is. So by in order to I would probably see primary lumbar curve. Okay, so one in 1B curves, a central line always like I should say view the vertebral body. You have to stable vertebra with more vertebra closely by. So in that would be you can use 11. This one, of course, there is acting 12 versus 1. This is what line reckons. Okay, so take a look. Look central and flat fair. Now, if you want T11 or even T10, this is one curve. So vertebral the number to L, we went to L1. Fusion in the present lumbar curve is fusion. In 1B curve, select you have to, it's not one find and it's not only T12 but years 50s more. In this article, we talked about the type length seeker. Noted that the lumbar curve would spontaneously correct recommended fusion to the neutral and stable vertebra, and if those two vertebra are different, they recommend going to stable vertebra. The idea is to avoid extending the fusion in the lumbar area to maintain mobility, which was the primary reason, and theoretically reduce the symptomatic distal degeneration. It has never been proved that in scoliosis, except if you go to L5, there is adjacent or distal segment degeneration after many years. So selective thoracic fusion, the goals of fusion are to obtain long-standing correction, achieve balance, at the same time maintain mobility. So Lanke classification was designed to improve inter-observer reliability and make clinical is more surgical rather than just on X-ray. So Lemke type 1 curve, 1C curve represents those previously termed as false double major curves, where the lumbar curve looks bigger but Lemke is C curves is selective thoracic fusion. And it's possible in almost all the cases. Well, that's what we followed. And you can see this curve, 68-degree thoracic, 66-degree lumbar. Now, this is a ratio that I've put in all the slides, which we'll see is really important to look for. This is a lanky 1C curve, as you can see here. And we did a selective thoracic fusion, and this is what happened to that patient. Post-op, 1 month later, 4 years later, it's a little bit better, but not perfect. We do trouble. Can we look? This is the ratio. Main thoracic to thoracolumbar lumbar curve should be, the ratio should be more than 1.2. So ideally, your thoracic curve has to be a lot bigger than the lumbar curve. And then you also look at the ATR, which is you measure by scoliometer, and also the rotation of the pedicles by Nash and Moe method on the X-rays. Newton also sort of focused on that, and basically it's a flexibility quotient that he came out. There are other papers that basically tell you that on a side bending correction of lumbar curve, 25 degrees is not the only criteria that you have to follow. You have to make sure that the lumbar curve is smaller and more flexible. So this is an article which discusses this age of the patient where they have open trident cartilages. So that is another factor that you want to consider. If the patient have open trident cartilages or are at research 0, they are going to grow even after your spinal fusion, and they may get lumbar decompensation if the lumbar curve is not completely balanced. And that's why it's less like selective thoracic fusion is less likely to be useful for those patients. So multiple papers, but at the end of the day, this is the paper that came out this year, I think a few months ago, and basically what they were saying is that selective fusion is associated with smaller lumbar curves, larger ratios of thoracic to lumbar apical translation, and rotation. So even though radiographically a lanky 1C curves are all the same as classified, they are not always the same. You have to make sure that the lumbar curve has to be a lot more flexible, not only flexible, but has to be, the thoracic curve has to be a lot bigger than the lumbar curve. The ideal number is 1.2, but that almost always varies. So this is what we did, and you can look at this. The lumbar curve is not as big, but more importantly, the translation is not as great as the thoracic curve. It is very flexible, and this is an ideal candidate to do a selective thoracic fusion. So what happens in long run? Well, this is a 5-year outcome study, and basically tells you that lumbar curve gets corrected, and in this paper, they showed a 32% correction at the first erect X-ray, which gets better as time goes by, and so the lumbar curve does spontaneously correct over a period of time, as you can see in this graph. And then long term, this is a 20-year follow-up study on, I think, a group of 20 patients, and then basically what they demonstrated that the correction of the lumbar curve tends to persist on long-term follow-up, does not lose a whole lot of correction after that. And mean L4 obliquity to the pelvis, as well as sagittal balance and coronal balance, remains stable over a period of time if you have selected the levels properly. So there are some exceptions, as we discussed. When you have thoracolumbar kyphosis in this area, you obviously do not want to stop. You should consider these curves as being primarily kyphotic rather than a scoliotic curve. And you want to go and capture the first lordotic disc. The first lordotic disc is being defined as the disc which has more anterior, is 50% more anterior opening as compared to posterior opening. Obesity is a relative contraindication to do a selective thoracic fusion, because even though you can stabilize their spine, they continue to grow sideways. And of course, larger curves. Now, you do not want to do, even in King's paper in 1983, they recommended not doing selective fusions for curves more than 80 degrees. So although the lumbar curve is completely correctable, it's not worth taking chances. And this is where I did the anterior release. We're going to see that in our next talk. So take-home points, all lanky 1A and B curves should be subjected to selective thoracic fusion. 1C curves are amenable to selective thoracic fusion. Unfused lumbar curve does correct spontaneously over a period of time, and short period of bracing, which we haven't discussed yet, but short period of bracing, especially when the patient goes in too much out of balance and the patient is young, who is, research sign is 1 or 0 or open trident cartilages, may not be bad to do a little bit of bracing just for the lumbar curve for a brief time. So magnitude on the lumbar curve and a ratio of major thoracic to the thoracolumbar lumbar curve, ideally greater than 1.2. You have to follow this rule. Should not be used for curves which are greater than 80 degrees, thoracolumbar junctional kyphosis, and obese patients. Well, does it really matter? We do not know by literature whether adjacent segment degeneration is an issue. We do know that lumbar motion does get affected if you do non-selective fusion. Take a look at this patient we just saw, which we classified as 5C. We fused her to L4, and this is what she does.
The paper is open for discussion.
So in the last picture, you emphasize that the more movement is there in the hip as well as other joints.
Well, this patient, she is a cheerleader, and she used to be a gymnast. And so typically we usually tell those patients who are wanting to do cheerleading or gymnastics that you're going to lose your motion and you may not be able to do it. And she took it as a challenge, and she's doing it. I don't know what's going to happen in future, but that's what it is.
Can I ask a question?
Yes, sir.
When we started learning the selection of fusion levels in correcting scoliosis, we were taught that try to avoid the junction area, like the thoracolumbar junction. But slowly come to hear that you can stop at T11, T12 level. Now, what's your opinion now? In selective thoracic fusion, like, can we stop it like that, or still I think that rule holds good?
So as long as on the lateral view your thoracolumbar junction is straight, there should not be any kyphosis, although truly the junctional kyphosis is anything more than 20 degrees as described by Harm study group. But I think in my personal opinion, it should be only either lordotic or completely straight. And in that case, it honestly does not matter where you stop, L1, T12 or T11.
Is there any more questions or suggestions? Let's move on to the next. The uniqueness of India. So we have a large cross section of socio-economic classes. All of them may not be able to afford the pedicle screws, very costly pedicle screws. Some of them do afford, but to practice deformity surgery in India, we should have many things in our armamentarium. So now we are looking forward to Dr. Abhay to tell us about the other methods than pedicle screws, which he is versatile in all of these. So
thanks.
We listen to
while this is loading, I guess we have some time. So there were some very elegant presentations so far from very learned faculty, and we're thankful for that. I just my presentation will sound as if I'm trying to sell a technique, but it's really not that. It's trying to get to ground realities. In our country, it's often said that you cannot practice scoliosis surgery if the patient cannot afford money, if the patient can't afford implants. And I just want to put that doubt to rest, and encourage everyone, as long as you follow the right principles. Implants are really something that are thrown at you. You really receive what you want, use the correct principles, and sieve it through your mind of common sense before you actually decide to say that I cannot do this surgery if I don't have these implants. And being in the place that we are in, we are forced to tackle children of all ages and all levels of deformity with obviously empty wallets. And you cannot put your hands up and say, I cannot do, offer you any solution. You have to innovate. You have to, bring back the common sense in you. And in my next few slides, I'm going to try and, delve on that. This is the technique of scoliosis surgery that has been lost somewhere in translation because of a huge variety of causes, certainly the least of which is not industry. A lot of, a lot of logistics and other implications have gone into pushing this technique out, and I may sound a bit cynical and sentimental, but the fact is that once you see the results of this technique, you will realize what I'm talking about. This is the technique of correction of a scoliosis deformity using very simple stainless steel rectangles and sublaminar wires. And the bad press that it got and why it got, I'm going to discuss that in a bit. The background, of course, was with this procedure. This is done in our unit about 20 years ago by my boss, Dr. Bhojraj. A simple H-rod, which has a little bit of distraction, along with sublaminar wires to translate. So this is the Harry Lukey construct, which had given consistently good results over time. It may not look so good considering today's fancy gadgetry available, but you need to see the end result, and this is done in KM Hospital, a public hospital in in central Bombay. So if you put your feet back on the ground, this is not such a bad thing. Now, the downside here, of course, was the distraction that was needed in using the Harrington rod, because the hooks will not sit in unless you distract the rod. So this evolved into the next technique, which was well described by Lukey actually, which we adapted, or many people in the world have adapted into using, instead of 2 Lukey rods, use a single rectangle, which is like a 2 Lukey rod with inbuilt cross connector, if you may, where a multiple number of events happen. As you tighten the wires on the concave side, you get a kind of a translation. Then as you tighten the wires on the convex side, that acts like a convex rod which pushes down the apex and pushes down the rib hump and gives some kind of a derotation. We studied this derotation in a paper we published on this, which I'll talk about, and there is derotation happening. And the whole thing about derotation is a mishmash, but there is definitely some derotation happening there as the convex rod pushes in. And here are some intraoperative pictures. For the faint-hearted, or for the people who have not been dabbling in wires, this looks like a absolute, chaos. Some 24 levels of doubled wires, popping out all over. But if you do this more regularly, there's a system to this chaos, and this can be nicely managed using a doubled rod, one on the concave side, one on the convex side. And consistently it can produce very good results on all fronts, and very good function, as we saw from Viral's. Our kids need to sit cross-legged, and they need to use a very specific position for toilet, and most of them go back to this. Most of our kids have been Indian classical dancers. Most means at least 1 in every 2 kid is a Kathak or a Bharatanatyam dancer, and they've actually gone back to that also, despite these being relatively longer fusions. So coming to the very crux of scoliosis surgery, the real aim for you and me is to give an enduring, effective and functionally good and a cosmetically acceptable result. The cosmesis should be from the surgeon's end and from the patient's end. Spinal function should be equal to suit the patient's need, and the result has to be long lasting. We cannot have our patients coming back because of decompensation. That's a fact. We cannot do a selective thoracic taking a chance that, okay, in 2 years I may have to go 2 levels down, because here in our country, one surgery should be the last surgery. Unfortunately, that's how it is. So in your effort to save a couple of levels, if you're going to make every 3rd or 4th patient come back for a second operation, that's a taboo. And so you got to analyze whether saving those 2 levels is doing a bigger favor than potentially getting the patient back on your OR table soon, because it means a lot to the families in India at least. Of course, the requirement of our surgery also should be that it should be safe, affordable, easy to perform, and widely applicable, not only indications wise, but in the corners of the country. So a lot of gadgetry, a lot of technological glitz should not be needed if this has to be performed in every corner of the country. And the technique that we are talking about, or I am talking about, really gives you just that. It gives excellent centralization and so big curves. I mean, we really don't almost never get a chance to operate anything under 80 degrees. So most of the times these curves are huge curves, and they get in line very nicely in the frontal plane. Sagittal contour is a revelation actually with this technique, and because you have two rods that actually can modulate the kyphosis or the lordosis, because they can pull and push the spine down. Derotation, like I said, we've got some statistics for that also. The convex rod, as you tighten it vertically down, you don't pull it back. So the concave rod is tightened, the concave wires are tightened to bring the spine towards the rod, but the convex wires are tightened from the top to the down, so it acts like a push. And very good cosmesis. So, I mean, most of the cases that, will keep coming up in the presentation, you'll realize that rib humps are corrected well, and, children are generally happy. And these are the kind of results in, pretty difficult, like this is a bad, really ugly neurofibroma. With a back and front surgery using a sublaminar wire and spinal loop rectangle, you can get it nice. Again, younger kids with decompensation. The cosmetic result, I think nobody can really challenge in most of the cases. Here's another, pretty ugly curve, all neurofibromas. So the point here is that it's a widely applicable technique also. You can use the same technique over and over for a variety of indications. Neuromuscular scoliosis obviously is a dream to do with sublaminar wires. You can get multiple levels of anchorage, and you can go all the way up. So we then analyzed a few of our cases some years ago, and as you can see, the average follow-up was not so good with our kind of setting, but 2 years is not such a poor follow-up. Of course, the total number of cases are less, but these are consecutive cases. They are not selectively chosen. And as you can see, the blood loss parameters, etc., everything compares pretty well with most other series. The degree of correction is pretty good. I mean, most of the series with third generation implants, the degree of correction ranges between 50 and 60, and so this is not too bad at all. And average loss of correction at 2 years again is not too bad, mainly because the wires are used at every level. So you have many more anchorage points than when you do screws, where typically when we do screws, we would try to skip levels to save money. If you put screws at every level, it would be a different story, but we try to save the costs for the patients. The specific complication that we have been worried about is this one, because this makes it cosmetically unacceptable, and there's been more than once that this has happened, where you stop short in the lumbar spine and they start getting a distal junctional kyphosis, and that big bump of the Hartschild rectangle starts poking out. We've had to revise one. We've had one decompensation for not going low enough, and this was an implant problem. We couldn't find a rod that was longer than this. Overall patient satisfaction rates were very, very competitive, and most of the patients who were questioned about their satisfaction rates were happy with their good long-term function, sitting cross-legged, dancing, bending down, etc. So what is really the problem? Like, who's pointing fingers and why? So I think these are the perceived disadvantages, and we should try and talk about them. Too many levels, what is the long-term function, what will happen when you have to go into the lumbar spine, and of course the safety of sublaminar wires, which has been, which has received bad press from a very, very specific group and a very specific journal. So the issue of too many levels, Viral touched upon it in the last talk, where we don't know how much low is low enough, and how many levels are are acceptable to be left behind. But in cases like these, where it's a touch and go between 1 or 2 levels, like here with a screw rod system, you would do this. Pictures from the textbook, mind you, or from a journal. The author has taken the level down up to here. If a sublaminar wire was used, this would have been the ratio. So you've actually just taken one extra level down if you had used a Hartschild rectangle and a sublaminar wire construct, as against if you had used it. So these are the curves that are very amenable to this technique, where it's a question of one level above or below, and you're really not getting into L4. You're staying on the top of L4. This becomes the easiest indication to switch from a screw rod system to a sublaminar wire rectangle system. And then long-term function has been evaluated. So there are a couple of very good studies. This is a 28-year-old evaluation of Harrington patients, and it's published in the Spine. It's a pretty decent study. If you read the study, there's very little loophole that you can find there. And I actually encourage you to read this because it gets your feet back on the ground reality. That low back pain and spinal fusion in the long term was not related to the fusion extent and the lower level of fusion. It's dramatic. It goes pretty much against what we think, but that's what he found in a significantly high number of cases and at a long follow-up. So also this other study from 2003. Hillenius' study, who's been from Finland. He's been recurrently, going back and looking at old H-rod patients, and again he found the same thing, that function as well as low back pain really did not make a huge difference what sort of a system you used at the end of the day on a long-term basis. If you have to go into the lumbar spine, you have to innovate, and both these cases or many others, we had to make screws which had a head that could accept a 6 mm stainless steel rod. Then we would cut the rod. This is a bit, technically a bit challenging, because when you cut